Daphna Stroumsa is an assistant professor in the Department of Obstetrics, Gynecology, and the Division of Reproductive Endocrinology and Fertility at the University of Michigan. In their clinical work and research, Dr. Stroumsa's focus is on provision of gender-affirming care and on sexual and reproductive services for gender and sexual minorities. Dr. Stroumsa is a recipient of an NIH K-23 Career Development Award. Their goal is to improve transgender and non-binary people's access to and quality of care through better understanding of the barriers to care that they face and through the development and evaluation of evidence-based, community-engaged intervention. Dr. Stroumsa received their medical education at the Hebrew University Hadassah Medical School in Jerusalem. They completed a master's in public health in the health management and policy at the University of Michigan and an obstetrics and gynecology residency at the Henry Ford Hospital in Detroit. They're a graduate of the National Clinical Scholars Program Fellowship in Health Services Research at the University of Michigan. We are extremely grateful for Dr. Stroumsa for making the journey to present to us and extremely excited to hear their work. Thank you.
Thank you. And thank you for that introduction. And thank you for those of you who are here in person. Thank you for those of you over Zoom. Our learning objectives for today are to understand the potential impact that federal and state policies may have on healthcare access for trans people. I will use throughout the talk the term trans as an umbrella term to refer to transgender, non-binary, and all people who are not cisgender, who do not identify with their sex assigned at birth. We will aim to recognize major factors affecting reproductive health for trans people, especially those assigned female at birth, and to discuss the data and knowledge gaps on pregnancy in trans people. I have no disclosures, although I should note that all hormones used for non-cisgender gender affirmation are off-label. And for the time being, I am funded by the National Institute on Minorities and Health Disparities. So I'll start with some context on the current policy climate. We will then discuss what we know about reproduction among trans people, in particular those assigned female at birth. I'll follow by sharing some pregnancy outcomes data, including my own, and we'll wrap up and end with some next steps and where we might be going from here. So for the political context, and we'll start before January 20th. As of a few weeks ago, 25 states had banned best practice care for trans youth. And it is a felony crime to provide certain kinds of best practice care for trans youth in 6 states. This is a constantly shifting map. The Montana Supreme Court just last month blocked their ban on gender affirming care for youth. But overall, these bans affect more than 1/3 of youth living in the country. And these bans have implications and translate to significantly increased travel time to the nearest clinic providing care. Often that means an absolute inability to access care. These maps might look familiar to you. We use the same models that the abortion access folks did. Our team pulled together census data and detailed clinic information to evaluate travel time to the nearest gender affirming care clinic providing care to youth by zip code. We compared travel times prior to any restrictions and following restrictions. So prior to restrictions is the map on the left. Following restrictions as of May 2023 is the map on the right. And of course, restrictions have increased since. We found that 1/4 of US youth now live more than a full workday away from the nearest gender-affirming care clinic. And these barriers not only affect access to care, but they can kill. A recent CDC analysis using the 2023 YRBS their same age. And these shocking rates are directly attributable to the legislative bans. In a recently published difference in difference analysis, Lee et al. Demonstrated a direct causal relationship between legislation and trans youth suicidality. They showed significant increases of between 7 and 72% in rates of past year suicide attempts among trans youth in states that enacted anti-trans laws relative to states that did not. And for all trans young people beginning the second year after legislation. So on the left, you'll see trans people aged 13 to 24. On the right, only teenagers up to age 17. The vertical line distinguishes the time period before and after the first enacted anti-trans law. And the y-axis shows number of suicide attempts per year. And you'll see average between 0 and 0.4, but a significant increase after that time period. So enacting anti-trans laws caused an increase in trans youth suicide attempts. And this is a large population. It is estimated that 0.6% of the US adult 13 and above population identify as trans. Looking from a different data set, so somewhat discrepant numbers, only at high school students, 3.3% identify as trans. That comes to about 1.4 million youth. Now, of course, not all of them will want medical intervention or medical care, but all of them are affected by this environment. Over the past 2 weeks, a lot has changed. And I want to review with you how we're starting to understand what things might look like based on the executive order issued immediately after the inauguration. So I'll share with you some snippets from the relevant executive order. First, the definition of sex. For the learners in the room, please don't quote this on your creogs or wherever. So female means a person belonging at conception to the sex that produces the large reproductive cell. Yeah. Male means a person belonging at conception to the sex that produces the small reproductive cell. And there's a 30-day window for the Secretary of HHS to issue clear guidance on what that means. Now, beyond the fact that this is a completely non-scientific definition, using the term at conception raises many significant concerns about reproductive health, and it remains to be seen how these will play out. Second snippet, federal funds shall not be used to promote gender ideology. It does not state which ideology and whose ideology, but I think we can make some educated guesses. And this has potential implications on care coverage and access to care. First of all, it will likely translate to limits on use of CMS coverage for gender-affirming care, primarily Medicare, Medicaid, by state. Probably there is some room there for states to affect that. It is likely that it will lead to reinterpretation of the term sex in Section 1557 of the Affordable Care Act. Section 1557 is the non-discrimination clause of the Affordable Care Act. And previous administrations, the Obama and the Biden administration, had defined through rules and regs the term sex to include gender identity and sexual orientation. A change to that section, or the interpretation of that section through rules and regs, will mean a loss of protection for non-discrimination, basically an open door for discrimination. Changes to CMS coverage are often followed shortly thereafter, but by changes to private insurance coverage. And of course, this statement will have far-reaching implications on our ability to do research and provide education. Some background to the next element of the executive order. In 2019, the Supreme Court, or maybe 2020 by the time the decision came through, the Supreme Court held that the prohibition on sex-based discrimination in Title VII of the Civil Rights Act includes non-discrimination based on gender identity, and therefore that an employer-based insurance plan cannot deny coverage for gender-affirming care. This was a lawsuit brought by an employee of the University of Arizona. Such denial would constitute a violation of the Equal Protection Clause. This is back in 2020. The executive order states that the Attorney General shall immediately issue guidance to agencies to correct the misapplication of the Supreme Court's decision in Bostock v. Clayton to sex-based distinctions in agency activities. Now, not being a legal scholar, but having studied the Supreme Court decision and its implications in healthcare, I think that the executive order misinterprets the decision, but my own opinion is neither here nor there. This could lead to broad changes in both workplace protections and access protections. What are the research implications? The executive order states that agency forms that require an individual's sex shall list male or female and shall not request gender identity. Beyond implications on trans people's ability to move through the world safely, this can have devastating effects on our ability to use a variety of data sources to identify trans people within it, and following that, to study trans health. Last week, the website for SGMRO, the Sexual and Gender Minority Research Office, went dark. This is the institute that coordinated NIH research on sexual and gender minority health over the past decade. And the office was essentially dismantled overnight. But while funding and coordination will be impacted by the executive order, the networks of researchers and much of the work achieved will not be lost. There are already alternatives and initiatives arising to meet the challenge. One last big element that might impact the world as we live in it in the next few years, at least, as it relates to trans healthcare. In December 4th, the Supreme Court heard oral arguments in the case of the US v. Scrimeti. This is a lawsuit challenging the state of Tennessee's ban on use of hormones and puberty blockers for trans youth. The petitioners, 3 families of trans youth, a physician, the ACLU, and until recently the Biden administration, contend that the law violates the Constitution guarantee of equal protection and should be examined with a higher degree of legal scrutiny. If the Supreme Court sides with Tennessee, it could give the green light to states to deny gender-affirming care for youth. That's over 1/3 of youth. A favorable decision would send the law back to the Sixth Circuit for reevaluation using heightened scrutiny, or potentially could even strike down the Tennessee law. Regardless of the outcome, which we expect by the summer, this will set a new standard for how we evaluated and view trans issues under the Constitution. So it remains to be seen how all these will play out in practice, but even prior to legislative attacks on trans folks, this population faced significant disparities. So I will review some of these, especially as it relates to reproductive health. First, we know that trans people face a host of health disparities, from rates of disability, cardiovascular health, for example, higher rates of stroke and MI in trans feminine people, metabolic health, higher rates of osteoporosis, mental health, sexual health, cancer prevention, lower rates of being up to date on cervical cancer screening in people who are trans. And the leading theory is that these disparities are caused by stigma. Trans people face stigma that is conceptualized on the structural, the interpersonal, and the individual level. The structural level is not being able to get the correct gender on your insurance card, for example. Interpersonal is the ways people are, for example, discriminated against directly or poorly treated by healthcare providers. The individual level is, for example, care avoidance because of fear of discrimination. And this stigma creates barriers to care, which therefore lead to disparities in care, in health, sorry. Beyond the direct effects of stigma on health, we know that stressors related to stigma, known as minority stress, adversely affect health directly through increasing the allopathic load. This is a term coined by Dr. Aline Geronimus already almost 3 decades ago from the University of Michigan. And this refers to the accumulated physiologic burden of HPA axis activation that minoritized people face. This in turn leads directly to worse health. Stress is, of course, intersectionally compounded. So people who experience various stigmatizations, minorizations, will experience that stress differently and will have it compounded. And we know that stress can affect reproductive outcomes. On the other hand, we know that gender-affirming care can improve mental health and decrease stress. But what effects does it have on reproduction directly? So when thinking about reproduction, we have these factors to think about. How does stigma affect reproduction? How does testosterone affect gonadal function, fecundability? And how do these affect pregnancy and postpartum? And I think the first question we need to ask is this an issue for trans people? What do we know about the interest in biological parenting among trans and non-binary people? So there's a high level of interest in parenting. 18% of a large survey of people initiating hormones in the US were interested in having genetically related children. A smaller study in Belgium showed even higher rates of interest in parenting. Of course, there are many avenues to parenting and to family creation where people have been excellent at creating queer family structures. But I think it's important to acknowledge that there is interest in this population in parenting. And of course, it's important to remember that parenting is obviously perhaps socially impacted. So it's influenced by social norms, acceptance, visibility, role models. And these numbers change and will fluctuate with changing attitudes and changing visibility. ASRM has an ethics committee opinion on reproduction in trans people. And the committee opinion recommends that providers should offer fertility preservation counseling before gender transition. There are no specific guidelines or standards about what the counseling should include. And part of the reason is that there is ongoing work on gonadal function during and following exposure to gender-affirming hormones, but actually pretty mixed and incomplete data on effects of testosterone on ovarian function. And of course, the question of fertility preservation brings up other complex issues beyond the necessity. Do you need to undergo fertility preservation prior to starting testosterone? And those are issues of cost, of experiences of affirmation, but also of dysphoria during the process, and a very controversial question on the need for testosterone discontinuation prior to fertility preservation for people assigned female at birth. On the other end of pregnancy planning spectrum, what are contraception needs in trans people? We know that there is likely suppression of the HPG axis with testosterone use and at least partial endometrial quiescence. A cross-sectional study of 41 trans men who carried a pregnancy more than a decade ago, of those, 20% became pregnant while amenorrheic on testosterone. A study of ovarian pathology at the time of gender-affirming hysterectomy showed that 1/3 of ovaries showed signs of recent ovulatory function, and this is for people on testosterone. And data from the PRIDE study, a survey of more than almost 1,700 trans adults assigned female at birth, reported that 21% of their pregnancies ended with abortion. So this underlines the importance of contraception counseling as well. There are several influential studies, primarily qualitative, which lay the groundwork for future work on pregnancy in trans people. The main recurring themes from these studies include the following. People shared that they had difficulties with the physical effects of pregnancy on their bodies. They had challenges in navigating the external environment, including family, healthcare providers, the general environment, their community. And importantly, the lack of representation of transness in healthcare in general, but specifically in OB care, added to the complexity of these challenges. And that's something that we need to keep in mind when caring for trans people in the obstetric or the OBGYN in general areas, that our world has been structured around women and is not appropriately structured for trans people, and that creates multiple barriers. Of course, many trans people will not share these experiences, but we need to remain mindful of them and work to undo some of them. While these studies established an important scientific understanding of experiences, they leave us wanting for more data, as these are smaller, non-generalizable by the nature of the qualitative work, and non-comparative studies. There are significant challenges to obtaining reliable large-scale data, especially when sex-gender data is not collected in national surveys. Few large-scale studies capture clinical pregnancy outcomes and patient-centered outcomes, but I want to share with you a handful that do, including my own. So the first, again, is the PRIDE study, a cross-sectional survey that captured almost 1,700 trans people assigned female at birth. Of those, 12% had been pregnant at some point, 12% were parents, and of those, a third had carried a pregnancy conceived with their own egg. Interestingly, non-binary people received different fertility counseling than binary trans men. And this finding points to possible differences in reproductive care by gender identity well before pregnancy, and kind of highlights for us, oh, this is an area that we should do some more work on. The second study I want to share with you is a population-based cohort which linked California birth records with hospitalization data. As you probably all know better than I do, in 2016, the state of California enabled birth certificates to include either a birthing mother, birthing parent, or birthing father, and the second parent could be mother, parent, or father. Triangulating that data with hospitalization data, Leonard et al. Identified both mother-mother dyads and birthing fathers. They had a birthing cohort of almost 1.5 million people, and they adjusted for sociodemographic factors, comorbidities, and multifetal gestation. They found almost 500 birthing fathers, and they found that those were not at a significantly elevated risk for any adverse obstetrical or birth outcomes. Almost as interestingly, or perhaps more interestingly, parents in mother-mother dyads, so presumed sexual minority couples, had higher rates of labor induction, of postpartum hemorrhage, of severe morbidity with or without inclusion of transfusion, but no differences in cesarean deliveries, hypertensive disorders of pregnancy, or preterm birth. The severe morbidity is identified using a CDC index of severe maternal morbidity, and it's a validated index. This foundational study leaves us with some gaps and questions. The validity of the methodology, as the authors themselves acknowledged, is unknown, as is the misclassification rate. For example, 42% of fathers in their cohort were not born in the US. Was this a language issue? Why is this cohort so heavily not born in the US? It also doesn't capture any pregnancies outside the great state of California. And the biggest question to me remains, if we can speculate that minority stress underlies the disparities in mother-mother dyads, why did we not see a signal in birthing fathers? If the underlying theory is that minority stress, either through direct HPA axis activation or indirectly through barriers to care, leads to health disparities, one would hypothesize that trans people are at least as vulnerable as sexual minority women. Specifically, there are few outcomes that we know in pregnancy are stress sensitive: depression, preterm labor, hypertensive disorders of pregnancy. And we know that cesarean delivery rates are sensitive to patient-provider communication. Furthermore, testosterone use may have additional effects on pregnancy. Testosterone impairs vasorelaxation, causes vasoconstriction. Testosterone levels correlate with preeclampsia and with blood pressure levels in preeclampsia. The androgen receptor is overexpressed in placentas with preeclampsia and can inhibit trophoblast invasion. And we don't know if these effects are lasting, for example, in people who discontinue testosterone before or early in pregnancy. But this does raise additional questions. So given these remaining questions, we aim to study pregnancy outcomes in trans people using a large data set, national data, and a validated methodology. We used claims data from Truven Market Scan, both Medicaid and commercial data sets, and looked at all deliveries in a 4-year period. We identified people as trans using an ICD code, which is a validated methodology, or additionally by sex as their gender marker. Our primary outcome was severe parental morbidity, the same validated index. And the secondary outcomes were cesarean delivery rates, preterm birth, and hypertensive disorders. We adjusted for variables which we had access to: age, race and ethnicity, chronic conditions, and antenatal conditions. We identified 256 trans people in the Medicaid cohort, 1651 in the commercial cohort. And we found things that we know are true for trans people in general. They were younger. They were more likely to have chronic conditions, especially in the particularly in the Medicaid data set. Notably, there were big differences in chronic conditions between the Medicaid population in general and the privately insured population in general, not surprisingly. And there were higher rates of anxiety and depression among trans people. The odds of severe parental morbidity were not different in either cohort between trans and cis people, and neither were the odds of preterm labor. We did find a lower rate of cesarean delivery in birthing fathers compared to cisgender parents. And we found a higher rate of hypertensive disorders in pregnancy in both cohorts. So similar rates of severe morbidity, similar rates of preterm birth, lower rates of cesarean delivery, and higher rates of hypertensive disorders. So our descriptive findings reassured us that we were capturing the population correctly. Our multivariate findings were somewhat surprising. The lower rates of cesarean delivery can be explained in a variety of ways. Are birthing trans people more likely to choose midwifery care over physician care? Are the characteristics of trans birthing people genuinely different from the characteristics of cisgender birthing people? Or is it the characteristics of the captured population, people who were out enough to their providers to have a diagnosis of gender dysphoria or a sex marker of male on their insurance data? But I'm perplexed by this data and I'm not satisfied with it. And it's always confusing when you have two big studies that use slightly different methodologies and find different findings. And then what you want to do is to do a third, better study. But regardless of what we find, we know there's a problem. We know experientially, anecdotally, that from the qualitative data, that trans people face an issue when pregnant, and we expect the problem to get worse. So what are some next steps that we can take? Regardless of how trans birthing people's morbidity rates compared to general or cis population, in order to improve the quality of care from wherever it is, we need studies that are powered to detect difference, that are sensitive to capturing subpopulation nuances and the population in general, and that are nuanced, that can help us understand patient-centered outcomes. We're currently in the process of collecting mixed methods data from a cohort of trans people with the aim of gaining better understanding of the relationship between patient experiences and clinical outcomes. Eventually, what we need collectively is a large longitudinal study. And that will mean that we need to start multi-center collaborations to collect this data. And we need to pay specific attention to subpopulations to intersectional identities. Given that we know that the bans on care and likely the executive order will affect health, we can expect to see effects on pregnancy health and care. And we need to remember that health of populations is dynamic. Some of the policy changes I described earlier are likely to have an impact on prenatal care access, to ART access, to mental health and to physical health at baseline, will certainly lead to loss of funding for support for DEI and training programs, and to loss of research funds. It is clear that we will need to be creative in terms of data sources, in terms of funding, and of course, in terms of clinical care. And it is important, I think, I have to stress that we must stay deeply engaged with trans communities to understand the evolving needs and priorities. Regardless of how we do the research, it is clear that we in the scientific, the healthcare, and the queer and trans communities are facing some steep challenges in the next few years. This clarity makes me all the more grateful for the opportunity to be here today, to connect, and to continue building networks of collaboration. It also makes me particularly grateful these days for my network of mentors, collaborators, colleagues, friends, and community members.